Hello and welcome to our webinar on New to Medicare Documentation Basics. My name is Jennifer Boniface and I am one of the nurse analysts with the Provider Outreach and Education team. This webinar is geared toward individuals with less than 6 months experience, as well as those looking to refresh their understanding of Medicare documentation basics. During today's session, we will focus on the fundamental rules and requirements for proper Medicare documentation. Proper documentation plays a crucial role in Medicare by ensuring clarity, accuracy, and accountability in patient care. As we've been told many times, if it's not documented, it was not completed. Thorough documentation allows the healthcare provider to paint a picture of the patient's clinical situation. And this is important to assist others with understanding what was done for the patient, as well as why it wasn't completed, or why it was completed rather. So comprehensive and accurate documentation also allows healthcare providers to substantiate the care provided and billed should the claim be reviewed by CMS or other Medicare contractors. Our objective for today is to provide a basic understanding of Medicare documentation requirements for healthcare providers. And we'll cover components of Medicare documentation, general elements of Medicare documentation, common documentation errors, the medical review process, and the CMS initiatives under the Improving Provider Experience program. So let's start with discussing what makes accurate documentation so important. Complete and accurate documentation is essential because it significantly impacts the reliability of data. Proper documentation serves several purposes. It verifies that the services billed by the healthcare provider were indeed administered to the patient and aligned with Medicare's coverage criteria. This ensures quality care is being delivered to all patients. Thorough documentation supports accurate billing and reimbursement for services provided to Medicare beneficiaries. It helps in justifying the medical necessity of procedures, tests, and treatments. Next, proper documentation ensures that healthcare providers adhere to Medicare regulations and guidelines. Lastly, accurate documentation promotes effective communication among health team members. So what components of documentation are needed? They can be defined using the 5 W's of who, what, where, when, and why. So let's begin with who. This includes identifying who is performing the service, who is supervising, who is the referring healthcare provider, and who is the patient. For the patient, the documentation should include their name, date of birth, health insurance claim number, and Medicare beneficiary identifier. Next is what, and then how many. This includes what services were provided, how many services or the quantity of services were performed, and the rationale for ordering any additional services. It also covers details such as the amount of time, tests, procedures, and dosages given. And quickly, I just saw in the chat, someone asked where they could obtain a copy of the slides. And just as a reminder, if you go onto our website under the Training Center page, you can find a copy of the presentation under live events. So moving on, third W is where. Where did the service take place? As in, what was the physical location of the service? Did it occur in a medical office, outside lab, outpatient facility, the patient's home, or another location? Did the service take place in more than one location, such as a medical office, followed by a separate facility for additional services? Next W is when. When did the service take place? Be sure to document both the date and time of the service. Finally, the last W is why. Why did the service take place? What is the medical necessity for the service? Be sure to document the patient's diagnosis and any related medical issues to support the justification for why the services were medically necessary. By incorporating the 5 W's into documentation, healthcare providers can ensure that every requirement is clearly addressed, making sure the services they provide are reasonable, necessary, and eligible for reimbursement. So now that we understand the 5 W's of documentation, let's dive a little deeper into the documentation requirements and the general elements of documentation. These elements include the encounter, reason for the encounter and relevant history, exam findings, tests and test results, assessment, plan of care, and signature with date as well as time when applicable. By focusing on the key W's and applying these general documentation elements, you will be able to create thorough, accurate documentation that substantiates the billed level of service. So we will start with the encounter and the reason for the encounter and relevant history. This is the interaction where the healthcare provider meets with the patient in need of care. First, we'll focus on the who is performing the encounter. This would be the healthcare provider. The healthcare provider may include a physician, a non-physician practitioner, such as a physician assistant, nurse practitioner, clinical nurse specialist, or certified nurse midwife, as well as a nurse or other specialist who meets with the patient. Documentation should include all individuals who are part of the encounter. In case of a split shared visit, the documentation should confirm the participation of both practitioners. Next, we address why, or the reason for the encounter. Documentation should explain why the encounter took place. This typically includes relevant past medical history. The healthcare provider can then ask additional questions using the 5 W's, such as why did the patient visit the healthcare provider? What was the main concern or chief complaint for the visit? Where did the encounter occur? Was it in a medical office, hospital, outpatient facility, lab, or another location? When did the encounter take place? Make sure to include both the date and time in your documentation. What occurred during the encounter and how many services were provided. Ensure the services performed are documented accurately and the quantity is correctly billed on the claim. As part of the review process, we require details about who provided the service, when it was provided, and how long it occurred. Many Medicare reimbursable services have specific place of service requirements. Some services also specify which healthcare provider must provide them. Additionally, certain services require documentation of the duration of the service and the time spent with the patient. As reviewers, we need to validate this information in the documentation to support the services as billed. By considering all these factors, the healthcare provider can ensure that the documentation accurately reflects the patient's presence at the correct facility, the billing of accurate dates of service, and receipt of the correct number of billed services. The next general element of documentation is the exam finding. During a clinical encounter, an exam may be performed. This exam may be a comprehensive medical assessment conducted by a physician or another qualified non-physician practitioner. The findings from this exam are typically documented in the physical exam findings section of the History of Physical, or H&P. Depending on the patient's condition, the exam may involve multiple body systems or focus on a specific area. The type and scope of the exam are determined by clinical judgment, the patient's medical history, and the nature of the presenting issues. The type of examinations and their descriptions can be found in MLN 906-764, Evaluation and Management Services Guide on the CMS website. Documentation should consider the level of medical decision-making required for a service as specified in the 2023 Evaluation and Management Services Guidelines. The 2026 CPT Professional Edition book outlines and details the 3 elements of medical decision-making which are used to determine the appropriate E&M code level. These elements include number and complexity of problems addressed at the encounter, amount and/or complexity of data to be reviewed and analyzed, and risk of complications and/or morbidity or mortality of patient management. To be eligible for a specific level of medical decision-making, the physician or qualified healthcare professional must meet or exceed at least 2 of the 3 elements at that level. These elements guide the provider in determining the appropriate examination and management of the patient. Documentation should accurately reflect both what was examined and the findings from the exam. Please note that Medicare does not require a specific format when completing the documentation. When billing based on medical decision-making, it's important that your documentation clearly reflects and supports the rationale behind selecting a specific level of care for the patient. This ensures the decision is clearly documented and aligns with the patient's clinical condition. When documenting the exam findings, providers should consider the 5 W's of who, what, where, when, why, and how many. Start by identifying the provider who is delivering the care. Next, consider what was done, where it took place, and when it occurred. For instance, what did the provider observe through sight, sound, touch, or smell? Where on the body were these findings noted, and when did the symptoms start? These questions help ensure a detailed and accurate assessment of the patient. For example, when assessing a patient's cardiovascular status, the following questions may be considered. What was the patient's vital signs, including blood pressure, heart rate and rhythm, respiratory rate, and temperature? What is the strength of the patient's pulses, and are they symmetrical on both sides? Upon auscultation, are there any abnormal heart sounds, such as murmurs, rubs, or irregular rhythms? Upon palpation, does the provider detect any abnormal chest wall movements, such as thrills or heaves? What is the appearance of the patient's skin? Are there any findings of cyanosis, edema, or jugular venous distension? Does the patient report any symptoms, such as shortness of breath, chest pain, or coughing? When did these symptoms first appear, and when did they worsen? Additionally, include details such as the patient's location immediately prior to the event that prompted their visit. Document the number of services performed. Were these services repeated, or were they separate and distinct from one another? Thorough documentation of these details helps the healthcare provider form a clearer and more accurate picture of the patient's condition during the encounter. Now, let's focus on the third element of documentation, tests and test results. The purpose of tests is to provide accurate and consistent information about a patient's health status, supporting the healthcare provider in making informed clinical decisions that promote better patient outcomes. Tests are conducted for several reasons: to assist in diagnosing a medical condition or disease by identifying the underlying cause of a sign or symptom, to screen for potential health issues with the goal of prevention, to monitor the progression of an existing condition or disease, to help determine the patient's prognosis for a particular condition or disease, and to guide the development and adjustment of treatment plans for those diseases and conditions. No matter whether the test is a routine one, such as measuring vital signs or body measurements, or a more complex test like laboratory or imaging tests, it is still essential that thorough and accurate documentation occurs following the completion of the test. By applying the 5 Ws during documentation, healthcare providers can ensure that their records are complete and accurate. So let's explore documentation for tests and test results using the 5 Ws. Who will be performing these tests? Who ordered the test? What was it, the treating healthcare provider, or was it from a referring specialist? What tests are being performed? What are the results from the tests? What diagnoses were made following the tests? Does the results for the test support the diagnosis? When is the test taking place? Is it a scheduled test, or does the test need to be performed immediately or with urgency? Where is the test being performed? Can it be completed in a medical office, or does the patient need to go to another facility to obtain a test, such as an outpatient laboratory or radiology center? Why is the test necessary? What factors played into the need for the test? What clinical findings from the exam determined the test was necessary? How is the test being obtained? Is it through venipuncture, patient-collected samples such as urine or sputum, radiology imaging, or another method? How many tests will be conducted? Is it a single test or a series of tests that need to take place? How will the test results be used in the plan of care or treatment plan? By answering these questions, the healthcare provider should be able to validate the reason for the tests being performed and support the rationale for subsequent care for the patient. Now that we've collected a substantial amount of information about the patient, we can begin to compile this information and develop it into a comprehensive patient assessment. The clinical assessment incorporates data from the medical record to create an overall impression of the patient's status at the time of the visit. This may include data from the history and physical, exam findings, and the test and their corresponding results. This documentation may be located in various sections of the chart. For example, to begin constructing an overall clinical assessment of the patient, we could start by reviewing the information recorded in the history and physical to establish a diagnosis. Following this, we could analyze the findings recorded in the examination to gain understanding of the patient's clinical condition. Additionally, we could review tests and their results to provide additional insights into the patient's clinical status. By using the 5 Ws when documenting within the medical record, we specify who provided the services, what services were provided, why they were necessary, when and where they were completed, how they were conducted, and how many services were completed. This ensures accurate and comprehensive documentation of all services rendered to the patient during the visit and ultimately validates that quality care was delivered to the patient. This is particularly important when justifying medical necessity and supporting accurate billing and reimbursement for services provided to Medicare beneficiaries. Once the clinical assessment is complete, the healthcare provider can then develop the plan of care. The plan of care addresses all the patient's identified issues. Goals are typically established to help monitor the patient's progress. The goals should be specific, objective, and measurable, and include timelines for achieving those goals. When developing goals, the healthcare provider should consider several factors, including what services does the patient require, are referrals or consultations with other healthcare providers necessary, and if so, who should be involved in the patient's care, based on the diagnosis and clinical impression, what treatments or medications are needed, how often should these treatments be administered, what are the appropriate dosages and frequencies for medications, how will their effectiveness be monitored, will the patient need follow-up visits, and if so, how frequently? Incorporating these W questions supports the creation of a clearer, more comprehensive, and goal-oriented plans of care. The final element of documentation is the requirements for the provider's signature and date, as well as time when it is necessary. All entries in the medical record must be signed and dated and include the time when required by CMS regulations in order to be considered valid. Medicare permits various types of signatures, including handwritten and electronically signed. The signature should be legible. A signature log or attestation statement may be submitted by the provider to confirm the identity of any illegible signatures. A signature log contains a list of type provider names along with their handwritten signatures. While it is recommended that providers also include their credentials on the signature log to prevent claim denials, it is not mandatory. An attestation statement may also be used to verify the identity of the provider when the signature is missing. The attestation statement should be signed and dated by the provider authoring the medical entry and should include enough information to identify the patient referred to in the note. Sometimes Medicare administrative contractors or contractors such as a Unified Program Integrity Contractor, a Supplemental Medical Review Contractor, a Recovery Audit Contractor, or a Comprehensive Error Rate Testing Contractor may require an attestation statement or a signature log to meet documentation requirements or to confirm authenticity. When this happens, they will ask the billing entity whether they would like to submit that information. For MACs and all contractors except CERT contractors, you have 20 calendar days to respond. This 20-day period begins either on the day the contractor makes phone contact with you or on the day you receive the request letter. If you submit a signature log or an attestation statement that resolves the signature issue, the contractor will review the related medical record entry. In this situation, the review period is extended by an additional 15 calendar days, starting when the contractor received your submission. And one important note, these timeframes do not apply to CERT review contractors. If using an electronic signature, the provider should include a statement confirming the signature was applied electronically, along with the electronic record. It is also recommended to include the date and time the record was authenticated. As outlined in MLN 905364, complying with Medicare signature requirements, practitioners using electronic signatures must ensure their systems and software are protected from modifications. They must implement appropriate administrative procedures that comply with recognized standards and laws, which may include password protection and other measures to ensure that only the practitioner can sign the document. Examples of language for electronic signatures can be found in the WPS's Guidance for Provider Signatures Requirements. And I also put a screenshot here in case you would like to see what are some of the examples that we put in that document. Stamped signatures are generally not accepted. CMS will allow certain providers to use a rubber stamp for their signature under the Rehabilitation Act of 1973, provided the author has a physical disability that prevents them from signing and can provide proof of this disability to a CMS contractor. By using the rubber stamp, the provider affirms that they have reviewed the document. When a provider uses a scribe to document medical record entries, whether it's a person or artificial intelligence, the provider must sign the entry to authenticate both the documentation and the care provided or ordered. The provider is not required to record who or what transcribed the entry. Documentation must include sufficient information to indicate the date when services were ordered or performed. If an entry lacks a date but is surrounded by dated entries immediately above and below it, the date of entry in question can be reasonably inferred upon medical review. Keep in mind, if the medical record lacks a signature after the date of service or within a reasonable time frame, it is deemed incomplete. In such instances, an attestation statement may be included in response to a documentation request. And for more information regarding signature requirements, please refer to the Medicare Program Integrity Manual, Chapter 3, Section 3.3.2.4, and MLN 905364, complying with Medicare signature requirements. And links to those resources can be found on our resources slide at the end of the presentation. In many clinical settings, it's common for a physician or non-physician practitioner to give an order verbally or over the phone to a member of their clinical team. For example, a provider may instruct a nurse to administer a medication. Before completing the task, the nurse writes the order on behalf of the ordering provider. These are considered verbal or telephone orders. All verbal or telephone orders must be signed or co-signed by the ordering provider. This signature confirms that the provider authorized the order and is responsible for it. For 42 CFR Section 482.24C2, all orders, including verbal orders, must be dated, timed, and authenticated promptly by the ordering practitioner or by another practitioner who is responsible for the care of the patient only if such practitioner is acting in accordance with state law, including scope of practice laws, hospital policies, and medical staff bylaws, rules, and regulations. To ensure our medical reviewers have a complete picture of the claim, it's important to submit a copy of the signed order, not just the verbal order or telephone order. This helps verify the service is promptly and properly ordered and supports the legitimacy of the claim. Next, let's review the responsibilities of the supervising physician when signing off on a clinical note. Sign off by supervising physician refers to the process where a licensed physician, responsible for overseeing another healthcare provider, such as a nurse practitioner or physician assistant, views and approves the care provided and the documentation submitted. The physician's signature signifies their agreement with the clinical decisions and the accuracy of the record. This includes reviewing the medical decision making to ensure the treatment decisions are appropriate, safe, and aligned with medical standards. The supervising physician also verifies the accuracy of the documentation, confirms the care meets the clinical and legal requirements, provides feedback and guidance when necessary, and ensures the provider is practicing with their scope of training and competency. By signing, the supervising physician assumes responsibility for the care, confirming their agreement with both the decisions made and the documentation. Another important consideration in the documentation process is the proper use of the copy and paste function within the electronic medical record. CMS has provided guidance on appropriate use of copy function, commonly referred to as copy and paste, copy forward, cloning, or cut and paste in the electronic medical record. When used correctly, this functionality can enhance efficiency by allowing clinicians to replicate consistent clinical information, such as updated medication lists or past medical histories. However, improper use of copy and paste poses serious risks. It can lead to redundant, outdated, or inaccurate documentation, which may compromise patient safety, reduce the quality of care, and result in compliance and billing issues. Examples of misuse include copying contact without verification, including outdated or false information, or failing to attribute the original source. Such actions can undermine the integrity of documentation and may result in fraud, waste, or abuse. CMS cautions that cloned notes lacking patient-specific details can create a misleading picture of the services provided and may support inaccurate coding, including upcoding. To avoid these issues, providers must carefully review, verify, and update all copied content to ensure it reflects the current encounter accurately and supports medical necessity. Best practices recommended by CMS and the American Medical Association include training staff, implementing clear documentation practices, using EMR tools to identify copied content such as highlights or citations, and conducting routine documentation audits. Ultimately, the responsible use of copy and paste is essential to ensure the medical record remains accurate, patient-specific, and compliant with regulatory standards. CMS created a decision table resource to guide providers and other stakeholders in using electronic health record features appropriately, maintaining accurate documentation, and reducing the risk of fraud, waste, abuse, and improper payments. And a link to this resource, Ensuring Proper Use of Electronic Health Record Features and Capability Decision Table, has been placed on the bottom of the slide for your reference. Before moving on, I want to briefly discuss the role of teaching physicians when a resident performs a Medicare coverage service. When a resident provides a Medicare coverage service, Medicare regulations require that a teaching physician be physically present during key components of the encounter and actively participate in the patient's care. To ensure compliant billing, the teaching physician must document their presence, summarize their involvement, and clearly attest to their direct participation in the service. Documentation by the resident alone is not sufficient unless it's supported by a corresponding entry from the teaching physician. Regardless of who performed the service, the medical record must include all required elements to support the medical necessity of the visit. If the resident completes this documentation, the teaching physician must review and verify its accuracy or supplement it with their own observations and findings. The medical record must clearly show that the teaching physicians either personally provided the service or was present for the key components and participated in patient care decisions. The combined documentation from both the resident and the teaching physician must support the medical necessity of the service. It's important to emphasize that a statement simply indicating that the teaching physician's presence does not, by itself, establish medical necessity or satisfy Medicare documentation requirements. And for further information on the roles and requirements of teaching physicians, interns, and residents, please refer to MLN 006347 or Guidelines for Teaching Physicians, Interns, and Residents. And a link to this resource has been provided on the bottom of this slide. Now that we reviewed the elements of documentation, I'd like to take a moment to discuss some common errors we often encounter. We explore these topics in greater detail during our webinars on medical review findings. You can register for these webinars by visiting the Training Center page on our website under the Live Events tab. Encore presentations of these webinars are also available on our YouTube channel under the playlist Encore Presentations. And I encourage you to attend these webinars, watch the Encore presentations, or both to learn more about these topics. There are several common errors we continue to observe in submitted documentation. The first common documentation error is missing information, including, but not limited to, missing dates and documentation lacking sufficient details. Next is missing signatures or unauthenticated medical records. This includes issues such as missing provider signatures, missing supervising signatures, illegible signatures, or electronic signatures used without adherence to the electronic record protocol or policy documenting the process. The third common documentation error involves providing services that do not meet Medicare's coverage guidelines for medical necessity. The last common documentation error is pre-charting or documenting the medical record prior to the patient's encounter with the healthcare provider. As a reminder, according to the Medicare Claims Processing Manual, Chapter 12, Section 30.6.1a, the service should be documented during or as soon as practicable after it is provided in order to maintain an accurate medical record. This aligns with the issue of timeliness. According to the Medicare Program Integrity Manual, Chapter 3, Section 3.3.2.5, Medicare expects practitioners to complete documentation at the time the service was provided. For additional details on timeliness of documentation, please refer to the Medicare Program Integrity Manual, Chapter 3, Section 3.3.2.5, and WPS's article, Complete and Timely Documentation of Medicare Services. Links can be found on the resources slide at the end of the presentation. Now that we've discussed what documentation our reviewers look for when completing a review, let's take a quick look at what the medical review process involves. The medical review program is conducted by Medicare contractors to help prevent improper payments and protect the Medicare Trust Fund. As part of this program, medical records and supporting documentation are collected and reviewed to ensure payments are made only for services that comply with Medicare's coverage, coding, billing, and medical necessity requirements. Errors may be discovered during the claim analysis phase, during the medical review, or sometimes both. Contractors use these findings to ensure payment accuracy, recover any improper payments, and provide education to help prevent future issues. Contractors perform several different types of medical review activities. One such activity is the Targeted Probe and Educate review process, carried out by Medicare administrative contractors. TPE relies on data analysis to identify providers with a risk of fraud, waste, or abuse. The process includes up to 3 rounds of prepayment or post-payment review, each paired with educational outreach. If a provider's denial rate remains high after the 3rd round, the case is referred to CMS for further action. Another initiative, the Comprehensive Error Rate Testing or CERT program, evaluates improper payments within the Medicare Fee-for-Service program. The CERT contractor randomly selects claims for review during each reporting cycle to verify compliance with Medicare rules. After the review, the CERT contractor notifies the MAC of any overpayments or underpayments. The MAC then takes the necessary steps to either recover or reimburse the identified amounts. Additional governmental entities involved in medical reviews include recovery audit contractors, the supplemental medical review contractor, and unified program integrity contractors. For more details about these organizations, please visit cms.gov. If additional information is required to make an initial claim determination, our medical review department may request medical documentation from the billing provider. And I'm going to briefly explain the process, then point out where to find more details on our website in the upcoming slides. Billing providers are required to submit the requested documentation to the Medicare administrative contractor within 45 days of the date on the additional documentation request letter. Failure to submit the documentation within this time frame typically results in the claim being processed without the necessary information, which often leads to a denial or rejection. A medical review calculator is available on our website. This calculator assists providers with determining the final date the documentation must be received. Under the drop-down menu, select Date to be calculated and choose Additional Document Request ADR, then select the initial date, and that ADR date will then be calculated for you. Additionally, if you look at the medical review page, you'll see the medical review calculator up in the top right corner of the screen, and I will show you that medical review page in a moment. ADR letters are sent to providers via the United States Postal Service. Registered WPS SNAP users in the J5 and J8 jurisdictions can also access ADR letters in the portal. Providers may respond to an ADR either through the portal or by mailing the documentation as hard copies or on a CD, DVD. Next, let's go to our website and review how to submit documentation for medical review. There are several methods available for submitting documentation. In this demonstration, I will guide you through the process for Targeted Probe and Educate program. This same process applies to all prepayment documentation requests, so once you're familiar with these steps, it will make any future submissions easier. So on the home page, go to the top of the page and click on the drop-down menu for the Topics Center. You will see various topics listed here, and we want medical review. So we're going to click on that medical review title. And just real quickly, I want to show you, here's that medical review calculator I discussed in the previous slide. So at the top of the page, you are going to find some clickable links for responding to medical review additional documentation request and Targeted Probe and Educate review process. These resources provide valuable information on the TPE process and how to submit documentation. You can also find helpful links under the documentation submission and targeted probe and educate dropdowns. So we're going to go to those. So under the documentation submission section, it contains resources on how to submit your documentation. And here's how to submit the medical review additional resource, documentation resource or the ADR. And here's one how to use the portal to submit prepayment, post-payment, and prior auth review documentation. The Targeted Probe Educate section lists resources for all topics currently under TPE review. So these are the ones that are on TPE view for J5B. And again, if you want to see the other ones, you just click on whatever jurisdiction you want, and I'll just click on J5A just to show you. Click on the Target and Probe and Educate, and they will list what topics are for that jurisdiction and that line of business. Now let's go over the various methods available for submitting documentation. And these options are outlined on our resource, Responding to Medical Review Additional Documentation Request. So we're reviewing some key information from that resource. The preferred method for submitting medical records is through the portal. And you can find detailed instructions for submitting documentation for an ADR request in the WPS SNAP Secure Net Access User Manual, and that is a clickable link. When submitting through the portal, please note that only one file can be uploaded per claim, and the file size must not exceed 15 megabytes. If you need to submit multiple files, they must be compressed into a single zip file containing no more than 60 files. Another method for submission of documentation is through the mail, and this can be formed one of two ways, either by mailing hard copy paper documentation or mailing documentation on a CD, DVD. For hard copy paper documentation, you may include documentation for multiple claims in one envelope. When submitting multiple ADR responses, clip Do Not Staple documentation for each claim separately. Use full sheets of one-sided paper. Do not use half sheets or double-sided pages. And if your facility uses double-sided forms, ensure the beneficiary's name appears on each page. When submitting documentation on a CD, DVD, name image files with the appropriate identifiers, such as the Medicare number and claim number. All images must be contained in a password-protected zip files. Email the password, mailing tracking number, if applicable, and date the documentation was sent to mr.adr.passwords@wpsic.com. And again, you can click that and it'll take you right to having an email. And that email should be sent on the same day or the next day after mailing the CD, DVD. And right here, I just want to point out some guidelines for the passwords to help you out when you're creating those passwords. When mailing confidential information, consider these following safeguards. Label the CD, DVD as restricted and/or confidential, and keep a shipment record in case the package is lost. And that medical review mailing address can be found here on that resource. And remember to send the documentation to the address that corresponds with your jurisdiction. So this one would be for J5. If you're going to use J8, again, go under the J8 tab at the top and make sure you use your J8 mailing address. Providers can also submit documentation through the fax. Fax documentation for each request letter separately. Do not send multiple requests in a single fax. Wait for confirmation your fax was successfully transmitted before sending the next document. Sending fax too quickly without adequate time between submissions can cause delay in processing. Only fax full sheets on one-sided paper. Do not fax half sheets or double-sided pages. And that fax number is listed right here on our resource. Finally, WPS also accepts documentation through the electronic submission of medical documentation ESMD system. And for more details about this process, visit the resource Electronic Submission of Medical Documentation ESMD on the CMS website. And again, that's a clickable link. And that brings me to a recent CMS press release from March 20th, 2026, which discusses a new rule that will phase out fax machines and paper mail for certain healthcare transactions. This rule, titled Administrative Simplification, Adoption of Standards for Healthcare Claims Attachment, Transaction, and Electronic Signatures Final Rule, will take effect on May 26, 2026. The rule sets national standards for sending clinical documentation electronically to support healthcare claims. It also includes requirements for electronic signatures to ensure the information is transmitted securely and properly authenticated. Covered entities will have 24 months from the effective date to comply, meaning full compliance will be required by May 26, 2028. And I am going to put a few links into the chat so that you will have that information. Oh, it looks like Leanne did that for me. So thank you, Leanne, for doing that for me. For all methods of documentation submission, be sure to include the request letter as the first page of your documentation packet. If the request letter is unavailable, include a provider-generated letter with the following details: the beneficiary's Medicare number, date of service, and a clear indication that the documentation is for medical review. Before I move on, I want to highlight an issue we've noticed when providers submit additional documentation in response to claim inquiries. Often they forget or omit to submit a cover sheet, an additional documentation request letter, or any form of identification indicating where the documentation should be directed. Without this clear identification, staff handling the paperwork face challenges in directing the document to the correct department or team. Consequently, crucial documentation may not be linked properly to the corresponding claim, which can lead to an increased likelihood of claim denials. To avoid these problems, providers should always place a copy of the ADR letter on the top of the documentation when responding to a request. This practice helps guarantee the documents are forwarded to the correct department for timely review. Alternatively, providers can use a cover sheet, which is typically provided to them, to clearly identify the claim and explain the purpose of their submission. Adhering to these guidelines enhances the efficiency of claim processing and lowers the risk of errors or denials. CMS established Medicare fee-for-service compliance programs to educate and assist Medicare providers in understanding and implementing Medicare fee-for-service policies. The goals of these programs is to help alleviate the burden on the providers. So we're now going to focus on 3 initiatives under the Improving Provider Experience program. The first initiative is electronic submission of medical documentation, or ESMD. The electronic submission of medical documentation system allows providers and suppliers to electronically submit medical documentation to review contractors, reducing the need to mail or fax documents and easing administrative burdens. And that new final rule should help with that. So if you're not familiar with the electronic submission of medical documentation, I would encourage you to learn that system, since that seems to be the way that they will be going forward in collecting information after the May 26, 2026, or I believe it's May 26, 2026 date. The next initiative is the Documentation Requirements Simplification, which is part of the Patients Over Paperwork initiative. DRS is designed to streamline documentation requirements, helping providers reduce paperwork and focus more on patient care rather than on complex and time-consuming claim documentation. The goals of DRS are to simplify and eliminate unnecessary sub-regulatory documentation requirements. And CMS welcomes any feedback or suggestions regarding this initiative. You can send your feedback and suggestions to Medicare Medical Review at cms.hhs.gov. And again, both this link and the next email link are hyperlinked, so you can send the email right from those links. The final initiative we will discuss under the Improving Provider Experience program is the Documentation Requirement Lookup Service. Medicare only reimburses for items and services when the documentation in the medical record fully supports compliance with all applicable coverage and coding requirements. The goal of Documentation Requirement Lookup Service is to allow providers the ability to electronically search document requirements. Objectives include reducing the documentation burden for providers, reducing improper payments and appeals, and improving provider to payer information exchange. And CMS welcomes any feedback. Should you have any questions or suggestions about the Documentation Requirement Lookup Service initiative, or are interested in participating in a future feasibility service, email CMS at medicaredrls@cms.hhs.gov. Thorough and accurate medical documentation is essential for many reasons. It confirms billed services were actually performed and meet Medicare coverage requirements, supports proper billing and reimbursement, justifies the medical necessity of procedures, tests, and treatments, helps maintain compliance with Medicare regulations, and facilitates clear communication among the health team members. Most importantly, thorough and accurate documentation ensures that every patient receives high-quality care regardless of provider or setting. So as a recap, during today's webinar, we reviewed the components of Medicare documentation, discussed the general elements of Medicare documentation, reviewed common documentation errors, explained the medical review process, and discussed CMS initiatives within the Proving Provider Experience program. The next two slides contain helpful resources. The first slide provides links to the CMS materials covered in this presentation. The second slide includes links available on the WPS website, including guidance on signature requirements, as well as tips for documentation. Please refer to these slides and use them as a reference when reviewing the presentation. Oops, went forward one too many. We are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions into the chat. So before we go to chat, I'd like to take a moment to answer a pre-submitted question we received. And the question asks, does an order need to be in place for every claim submitted under the provider's name? For example, an order specifically for a 2 business day post-discharge call in transitional care management. According to CMS guidelines, services billed under a provider's name must be medically necessary, properly documented, and performed under appropriate supervision. However, not every service requires a separate written order. For example, in transitional care management, which includes the required 2 business day post-discharge call, Medicare does not require a separate order just for that call. However, the provider must document 3 things: that transitional care management services are initiated, that interactive contact with the patient occurred within the required time frame, and that they assumed responsibility for managing the patient's care after discharge. So to learn more about transitional care management services, please refer to MLN 908628, and Leanne will place a link to that into the chat. So I'm just quickly looking at the chat real quick for questions, and there was actually it looks like all the questions were answered, so we are going to move forward in the interest of time. Please take a moment to complete this survey and share your feedback. We use your feedback to develop topics for future education. And you can access the survey by either clicking the link in the chat or by visiting the CMS Qualtrics page after the webinar. I apologize, the CMS Qualtrics page. In a few minutes, you will receive an email thanking you for attending, which includes your certificate achievement and a link to the survey. If you need contact hours for continuing education, they will also be in the email. If you don't see it, check your spam folder. If you called in, so you will not be receiving the email, just email us at wps.gha.education@wpsic.com with the webinar name and phone number, and we will send you your certificate of achievement. If you think of any additional questions after today's event, you have 7 days from today to submit them. Send them to our education mailbox at wps.gha.education@wpsic.com and put the title of this webinar in the subject line. However, if you have claim-specific questions, please direct those questions to our customer service department, as we don't have access to your claim information and are therefore unable to look up claims. Also remember that we cannot accept any type of PHI or PII via email. Finally, on behalf of myself, Leanne, and all of Provider Outreach and Education, thank you for attending today's webinar on New to Medicare Documentation Essentials. As a reminder, this presentation will be posted as an encore presentation on the Training Center page on our website. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us for future events. You may now disconnect.